I am, of course, a pediatrician. I'm a father. I have two boys, Miles and Nathan. They're 5 and 8 years old, and a wonderful wife. And I grew up in Southern California, went to UC San Diego for my undergrad, and went to New York Medical College for my medical degree, and then trained for residency at Harbor UCLA Medical Center in LA County. Most recently, I worked for Kaiser before coming down here to work with Dr. Hoang to start this practice.
I'm Lisa Hoang, and I'm also a mother as well. I have 3 little girls, 4, 8, and 10, and 9 and 11 now. Sorry, 4, 9, and 11. And before coming here to start the practice with Dr. Maynard, I was working with St. Joseph's in Tustin. So we're new. This is a new practice, but we're not new doctors. I went to school in UC San Diego, and I did my residency here at Chalk. So I'm also spent most of my adult life here in Southern California, and my family's here in this community. So we love it in South County, and this is where our family is as well. We are off of Crown Valley, right next to the hospital, and so it's the newest pediatrics department that Providence has. So we're happy to be here too. We both feel really strongly about being a team with the parents, working with parents. So that's why we do these educational seminars or webinars, because we do feel, it's important to be knowledgeable about what you're getting into.
All right, and without further ado, I guess I'll go to the next slide if I can get it to go. Okay. And it's not working. Hold on one sec. That's one way to do it. All right, so we have a variety of topics. Of course, there's so many things with newborns. We're not going to cover every possible bit of advice or information we could give you, but we try to get some of the high points for you. Talk a little about the prenatal period, about being in the hospital after the baby is born, feeding, diapers, cleaning the baby. I also prepared some benign findings, things that a lot of parents notice that end up being normal, but because you don't see it in other children, you might be worried about. So we can talk about that a little, talk about sleeping, and we'll talk a little about postpartum depression as well.
And I'd also like to add that at the end, we'll try to save some time for any questions that you guys might have as well. So we'll have that. And then, of course, go ahead and use the chat too.
All right, so first up here is, before you are going to have your baby, you probably should, it's a good idea to select a pediatrician who will handle the care of the baby once they're born. And this is just some examples of questions you might want to ask, things you might want to know ahead of time before you have the baby. For instance, hospital privileges. What hospital does that pediatrician usually admit patients to? If you're going to have the baby in that hospital, do they have a NICU? Or if there's a problem, God forbid, with the baby, will they have to be transferred? It's a good idea to be aware of that. Newborn rounding, some doctors will not actually round with the baby, or in some cases, they may be part of a large group where they take turns rounding on babies. In our group, we actually switch off every week. So this week is Dr. Hoang's week. And insurance, of course, is always important. You should be aware that the baby is covered by mom's insurance in the first month. So that's going to be kind of affecting your decision on choosing your pediatrician. And
because it makes it automatic coverage. What did I
I'm hearing something in the background, but I don't think that's okay. So so communication is important too. How available will your doctor be? Do they have any message service? Are they available on email? Do they have an advice line? Things like that can be important. And also, there's some special concerns you might want to think about. Circumcision would be one of them for males if you want to do that. Some pediatricians do circumcision, some don't. So it's something you'd want to ask beforehand. If you have special concerns about vaccinations, about any of the care the baby will get in the hospital, it's a good idea to bring that up. Talk to your doctor or a doctor that you're interested in ahead of time. And of course, there's a lot more to do in the prenatal care time. I didn't really put that in here, like getting a crib, making sure you're ready. But this at least is part of that, is an important part of what you should do in preparation. And so you find your pediatrician, and then what do you know? The baby's there.
Dr. Maynard,
Yes.
can you explain what's rounding?
What rounding is? Yes, rounding, I used physician terminology. That means if a baby is in the hospital after being born, a doctor needs to go and see that baby every day. That's called rounding, going around to see all the babies you're taking care of. So some physicians, like I said, will be there to round on the baby. Others may use a hospital service, someone who just professionally works in the hospital to do the rounding. In our case, we do our own rounding. It's Dr. Hoang and I, and we take turns doing it every week, every other week. So that's what that means, coming to see the baby every day in the morning.
So we will see the baby from when they're born and then also in the office as well.
Right. And that I address that a little bit in the next slide here. So then the baby's here. This actually is a picture of a pretty new baby. You can tell because of the sort of the caseous material, the white stuff on their skin. That baby was just born not too long ago, looking nice and chubby. And when babies are born, it's standard of care to give vitamin K. Vitamin K is to prevent bleeding, especially bleeding in the brain of babies. The hepatitis B vaccine is given. That's to temporarily protect the baby from hepatitis B, but it doesn't complete their vaccination. And then the erythromycin ointment on the eyes is to protect infections of the eye that can cause blindness. So those three things are usually done pretty quickly after the baby is born. In terms of how long you'll stay in the hospital, that really depends also on how the baby is born and how everyone's doing. We don't send the baby home without mom usually, and we don't send mom home without the baby, so it's kind of linked. But usually if it was a natural birth, a vaginal delivery, it's going to be 24 to 48 hours stay. If it's a C-section, it's going to be 48 to 72 hours staying in the hospital. And every day that the baby is there, a pediatrician should be rounding or checking on the baby. There's also standard hearing and heart screens that are done by technicians in the hospital. There's a newborn screen, which requires a little bit of blood, but that's sent out to a California laboratory that performs those tests to look for rare genetic diseases. Jaundice checks are also an important part of the baby's admission. So they will look to see if, of course, to see if the baby is looking yellow, but we actually have instruments to test the level of something called bilirubin. And bilirubin is what causes that yellowing of the skin, and we make sure it doesn't get too high. There usually is the chance to talk to a lactation consultant and learn about breastfeeding. And usually the nurses in the maternal mother-baby units will be able to give you advice on that as well. And then during those visits with the pediatrician, when they come every day, you should be able to schedule your first follow-up for the baby, which is about 48 hours after discharge. So after you leave the hospital, about 48 hours later, we always like to check on the baby, make sure they're still doing okay, make sure the breastfeeding or the nursing is going well, and sometimes check on jaundice again.
Dr. Maynard, we have a
Yes.
question about delaying hepatitis B. I'll let you take this one. So would you recommend delaying Hep B vaccine until their next visit or getting it right away?
I wouldn't recommend delaying. The reason that we do that Hep B vaccination is to cause an immediate immune reaction, which is what immunizations are for, but that's specifically to protect from any possible exposure to Hep B during the delivery and in the hospital. It's a temporary protection. If you wait, it really isn't going to help that much. That protection that you get from that first shot doesn't stay around a long time, which is why we have to vaccinate later, starting at 2 months. But I don't recommend delaying the Hep B vaccination. There really would be no point in doing it 2 or 3 days later. It wouldn't have the benefit that we're looking for.
Another question is, do we circumcise at the hospital? Yes, we both do circumcisions at the hospital.
Yeah. Any other questions before we move on? All right. So next slide here. All right, this is you.
Okay. We do have another question. When the baby have Hep B antibodies from the mom and also erythromycin, what's that for again? You want to take that before we move on?
Can you repeat the second half of that question?
Oh, sure. It's also in the chat. The question is, when the baby have the Hep B antibodies from the mom? And the second question is also erythromycin. What's that for again?
Okay. Yes, there is transfer of antibodies across the placenta. And so temporarily, yes, the baby does get Hep B antibodies from the mom. Sometimes the problem with Hep B is often people have it and don't know they have it. And because of there's uncertainty there, we don't know if the baby's getting the protective antibodies. So giving the vaccine will ensure that the baby's own immune system revs up against Hep B and prevents infection during the possible exposure period. So it is good if mothers get their vaccination. And I do encourage all mothers to get all their vaccinations up to date during pregnancy, because they are giving some protection to their child. But I think that extra Hep B is still a good idea, that extra Hep B vaccination for the actual baby. And then erythromycin is an antibiotic. It protects against bacterial infections. And for a really long time, pediatricians and hospitals have been giving antibacterial treatment to the eyes of babies because it was recognized that bacterial infections to their eyes can cause blindness. The specific bacteria usually that has caused it historically is gonorrhea and chlamydia, and erythromycin kills those bacteria. So that's the purpose of that. It's a one-time treatment. It's very safe. It's just an ointment that goes on the eyes. It makes the baby's eyes blurry temporarily, but that period of time is really brief. And then they spread it out by blinking, and that is all the treatment they need. That's what the erythromycin ointment is for.
Okay, thank you. So now about what to feed your baby, which feed your newborn. So as we all know, the two options are breast milk or formula. I'm going to go ahead and talk about breast milk first, and then I'll talk about formula. So breast milk is really the recommended nutrition for the baby. It has all the nutrition that your baby needs. It protects the mother and the baby against illnesses. It can lower risk for the baby for risk of asthma, diabetes, respiratory disease. It can protect against gastrointestinal disease. And so it really is beneficial for the baby. For the mom, there's also benefits as well. It does protect mothers who breastfeed do seem to have a lower risk of things like breast cancer, ovarian cancer, diabetes, hypertension. So it's really beneficial to both the mom and the baby. And so the AAP recommends breastfeeding to at least 6 months. You can breastfeed longer than that, but we want to try to shoot for 6 months. And if you want to breastfeed longer to a year or beyond, that's okay. You can do that. It does help with bonding. It's still nutrition. So you can continue to do it to a year or even longer if you can. It will need to be supplemented with other food as the baby gets older, solids, and then other forms of liquid nutrition that have more vitamin D and calcium in it. There are very few contraindications to breastfeeding. Some of them would be certain infant diseases there are certain infant diseases where breastfeeding is contraindicated, metabolic diseases, for example. There are certain maternal conditions where breastfeeding is contraindicated, things like HIV, tuberculosis, active tuberculosis, Ebola. So that's definitely something we'll talk about, but there's not very many contraindications. Even if you have COVID, you can still continue to breastfeed. There's other diseases like on the skin. So herpes, for example, if you have chickenpox or if you have herpes or if you have shingles in that area, that's another contraindication to breastfeeding. But in that case, you might be able to pump and give that to the baby. Let's see, what else? Substance abuse, of course, because there are certain drugs that can go into our breast milk. Substance abuse, illicit drugs, PCP, cocaine, does pass through the breast milk. So those are things that we discourage or where breastfeeding is contraindicated. Certain medications, chemotherapy, radiation is contraindicated. If you get started on any medication, it's best to talk to your pediatrician so that we can help you and guide you to see if it's safe for the baby. A lot of times, some of it, a small amount of it will go into the breast milk, but it probably is okay. And there's a whole database of giving us a little bit of guidance around that. So we can talk to you about that if you do get started on, say, like an antidepressant or an antibiotic or something, okay? Next one is pacifiers. So pacifiers, not a bad thing, but we do recommend trying to establish a good latch and establish good nursing habits before we introduce the pacifier. Babies love to suck. In fact, pacifiers are good for calming the baby. They're good for soothing the baby. It does reduce the risk of SIDS. So it's not like you can't ever use the pacifier. But sometimes if they're sucking too much on the pacifier, they get used to that shape. They may not like the breast or may not have as easy a time nursing. So try to get that latch and the breastfeeding established first. What else? Donated breast milk. So it's okay to use donated breast milk. There's very few diseases that are transmitted through breast milk, but things like HIV, Hep B, Hep C, certain medications can be transmitted through breast milk. So it is recommended that if you do use donated breast milk, that you use it through a bank as opposed to getting it from, buying it off the internet or something like that, because you really don't know. It's not been screened what the mother has or doesn't have, what medications she may or may not be using. And also handling, is it handled well? Is it a clean, sterile environment? So if you do use donated breast milk, get it from a reputable source. And oops, I lost the slide here. Oh, there you go. What about breast milk supply? So at first, the supply will be very low. You're going to get mostly colostrum, which is a thick, concentrated, yellowish, clear, whitish liquid, right? But it is really concentrated, full of good stuff, even though you don't get a lot of it. It will provide nutrients and fluids for the first few days, so that's okay. Still put your baby on it, still allow your baby to get that. You want to try to feed the baby frequently those first few days to start to establish some supply. Babies need to be fed every 2 to 4 hours, and sometimes even more than that. The first day they may be a little sleepy, and then day 2 or day 3, they'll want to feed a lot more. They may have some cluster feeding sessions, and then once your milk is established and your supply is established, then they may be able to space that out a little bit longer, 3 to 4 hours or so. Okay. Initially, though, you may have to wake your baby up just to help your body establish that supply. Exclusive or partially breastfed babies do need vitamin D supplementation. So that would be, you can buy it over the counter. It's just a vitamin D drop. You can get it, depends on the one you buy. It will either be 1 ml or they do have some that are half ml. And then there's also one that's like literally a drop. And so as long as it has 400 IU, you can give that to your baby every day if you are exclusively or partially breastfeeding your baby. Next slide, please.
Just briefly, there was a follow-up question to one of my previous questions. I just wanted to circle back to. I didn't want to ignore it. There's the question about the erythromycin ointment. If we don't have those STIs, sexually transmitted illnesses, do we need the erythromycin? And the short answer is, if you can be absolutely sure you don't have it and couldn't possibly give it to the child, technically, yeah, you don't need the erythromycin. It's still, though, the standard of care and what's recommended in the United States, although some countries have moved away from that and don't necessarily require it. But because I can't absolutely know the mom's status, even if they had a negative test a week before, I do still recommend to my patients that they just do the erythromycin just in case. However, I have had instances where parents say they don't want it, and if they understand the risks, that's fine. That's their choice. All right.
So the other follow-up question was, does every doctor give the ointment? So you want to take that?
Yes, to my knowledge, well, I haven't asked every doctor, but to my knowledge, that's just the standard for any baby that's born. And the doctors actually don't give it. It's in the standard order set. The nurses give it immediately after the baby is born.
The other question for vitamin D drops. So there isn't a particular brand that we recommend for vitamin D. There's a lot of different brands out there. They're all pretty comparable. It just depends on what you're comfortable with. Just make sure that you read the instructions on the bottle because some are more concentrated than others, okay? And you can buy it over the counter. If you go to any pharmacy with a baby section, or even, Target and any grocery store, if they have a baby section, you will see that vitamin D, the vitamin D section, it'll say no vitamin D for babies, and it'll be 400 IU. Okay. Okay, next slide, please.
There you go.
I thought this was helpful because this comes up very frequently. If you're pregnant and you haven't tried to think about what kind of pump to get or whether or not to get a pump, I want to tell you that it is covered by most insurances. So as you get closer to the end of your pregnancy, 30, 35, 36, 37 weeks, think about what kind of pump you want, find out what your insurance will cover, and then you can usually ask the OB to fill out the form so that you can get the pump maybe before your baby is even born, okay? And this is some information about storage guidelines. So you can pump and keep breast milk out if it's freshly pumped or pressed up or expressed up to 4 hours. If you put it in the refrigerator, you can keep it longer than that. If you have a good freezer, you can freeze it up to 6 months or a year, okay? If your freezer is good. If it's one of those freezers like where it's you're putting everything on the door, then every time you open it, it's a little warmer. So make sure you put it a little bit deeper in or further back. Try not to put it on the door. And if you have one of those deep freezers where you can, make sure that the temperature is really good down there, you can even keep it up to a year. So we call it liquid gold. So if you can pump it, if you have even a little bit of it, save it or give it to your baby because it's still good. Once you freeze it and thaw it, it's good for a few hours. If you thaw it and you put it in the refrigerator, it's good for up to a day. Just like for meats, you shouldn't, it's not recommended to thaw something and then freeze it again and then thaw it and freeze it. Okay, so if you are going to use it, thaw it. Otherwise, just hang on and don't thaw it yet. As far as leftover from feeding, so if the baby started eating it, then you should probably finish it within the first few hours. You can't have them sucking on it and then use it later on that night. What you can do if you thawed it and you know that you have a big old bottle of 4 ounces or something, you thawed it, you can pour a little out and put the rest in the fridge, and you can keep that in the fridge for up to 1 day. Okay, and then just use half of that. You just don't want to be feeding the baby because the babies do backwash, and so you don't want to feed the baby and then it's a half-eaten bottle and then use that later on that night. Okay. Another tip about breastfeeding: make sure that you do label it so that you can kind of get a sense of how old the milk is. Label it with the date, and then once you start going to daycare and intermingling with other kids, make sure that you label also with your baby's name. Okay. The date is important because you want to try to use all the old stuff first so that you stay as fresh as you can get. Okay. And if you are pumping at work or something like that, and you don't have a freezer or a refrigerator at work, you can keep it in a cooler with an ice pack for up to 24 hours, and then you can put it in your freezer that night. Okay. As far as microwaving or as far as warming, no microwaves, because what happens when you microwave it, it doesn't microwave completely. The heat doesn't get distributed evenly, and you might get little hot pockets in the breast milk, and that can hurt the baby's tongue. So you want to make sure that when you are warming up breast milk, that you try to warm it, stick it in a bowl of warm water, or you can warm it under a sink of running water, but don't stick it in the microwave. Okay. Next slide, please. Now, formula. So we talk a lot about breast milk, and breast milk, you try your best to do that, but there is another option if breastfeeding doesn't work out. So if you can breastfeed, or if you can give the baby breast milk, great. Pumping and nursing will give the baby the same benefit as long as they're taking that breast milk. But sometimes we do have trouble with nursing or breastfeeding, and sometimes we do need to use formula. Okay, so with formula, this is a standard store-bought formula. The way to make formula is you want to measure the water first, and you want to do one scoop to 2 fluid ounces. So you would put water in, clean water in bottles up to 2 ounces, and then you put the the scoop in there, okay? And then you can mix it up. Try not to, too vigorously shake it, just kind of stir it. You don't want to add a ton of bubbles in there. A lot of people ask me, do I need to use like specially bottled water or specially bought baby water or something like that? And that's not necessary. We live in Orange County, so our water is pretty clean. So as long as you're not using well water or something like that, you can use just, water that you would drink, okay? Make sure that the area that you're preparing the formula is clean. So as long as, don't prepare your formula in the same area where you're preparing your chicken. So have a designated area that this is where we're going to prepare the formula. It doesn't have to be a big old space, just a small space where it's not being mixed with a lot of other bacterial things. There's a few types of formula. I already talked about powdered formula, but there's also pre-made formula, and then there's also concentrated formula. So pre-made, you may have gotten some samples. The formula companies like to give out lots of samples, and you may have gotten some samples of pre-made formula. So these are sorry, not pre-made, ready to drink formula. These are formulas that come in, they usually come in a little bottle of 2 ounces, and you can just put a nipple on and feed it. Do not add any water to the ready to feed formulas. Now there's also concentrated or concentrated formula, and then that's the one where you need to add water. So make sure you read the instructions carefully. So pre-made or ready to feed formula, you don't need to add any water. Powder formula, you need to add water, and there's also concentrated formula where you have to add water. Okay, so check to see which one you get. A lot of patients also ask me which one is better, and to be honest, the formulas are all pretty comparable. All the formulas in the US are FDA regulated and approved. They all have the standard amount of most important nutrients that the babies need. You will get a lot of marketing as moms and dads, and you'll get the marketing saying this one has a little bit more of this and this one has a little bit more of that. But it's a lot of it is marketing. There's not enough information to say this is the superior formula. Okay, there are a few exceptions. There are some babies who will need special formula, and those are the ones that do have certain types of allergies, or if they have certain types of intolerances. And we recommend that before you switch to specialized formula, come talk to us. Come talk to us, and we'll help figure out and tease out all of those things. But if your baby's a normal newborn baby, they can get the normal newborn standard formula. Okay. Make sure you check the expiration dates on formulas, because they do expire, especially if you get them from friends or families. We get a lot of samples as moms and dads for formula. So if we don't use it, we end up giving them away. But make sure that you look to make sure the expiration date is there and it hasn't been reached. What else do we need to say? Oh, to warm or not to warm. So it doesn't matter. You could warm it if you want. Warming it is kind of nice because it's more reminiscent of breast milk, because your breast milk is warm. So if you want to warm it, you can, but you don't have to. A lot of babies just take formula room temperature. Just make sure that it is thoroughly mixed, and so that you don't have chunks of formula in there. And if you are going to warm it, don't use the microwave. Make sure that you warm it either in running hot water or you put it in a water bath. That way it gets evenly heated up, whereas the microwave may give little pockets of heat. Next slide, please. And Spitups and GERD. We can't talk about feeding without talking about Spitups and GERD. So all babies will have a little bit of Spitups. All babies, because they are new, they're getting used to all of this, they will spit up a little bit. Now, sometimes it's not problematic. If they're gaining weight and they're not super fussy or not super bothered by it, then we call them happy spitter-uppers. It's a little more laundry for you, but it may not be a bad thing. There are some supportive measures that you can do to minimize the spit-ups. So you could burp the baby, because that does help with the spit-ups. You could do smaller volumes and more frequent feeding. So instead of doing, 4 ounces every 4 hours or something, you might be able to do 2 ounces every 2 hours. So then that way it's a smaller volume. It doesn't fill up their tummy as much, and so that may minimize or help with that. Keeping the baby upright. So sometimes when you burp the baby might not burp, and that's okay. If you're worried about it, you can keep them upright for another 20 minutes or so, and then that seems to help as well. Now, we don't recommend any pillows or blankets or anything like that in the crib or bassinet. So the way that you can put your baby upright is you could lift the mattress a little bit and put something underneath the mattress, because the baby should still be sleeping on a flat, firm surface. So keeping them upright a little bit may also help, or you can just hold them for a little bit. But sometimes that can become very tiring too. So those are some measures that you can do. Sometimes you do all of those things and we still may have a problem. And if the baby is spitting up so much where they're not gaining weight because they're spitting up a lot, or it's just very uncomfortable for them, they're arching their back, they're crying, they're super fussy, and that's when we may need to use medication. Usually Spitups or GERD will peak at around 4 to 5 months of age because that's when they start to outgrow. Next slide.
All right, so this is my slide. What's in the diaper? Oh, what's going on there? Okay, I fixed it. You know, diapers are going to be part of your life for a while, and especially when the baby's new. The first stool usually happens within 24 hours. Some babies poop right there when they're delivered on the table. Others take a little time, but it usually happens eventually. That's part of the reason we keep watching them in the hospital. The first poop is called meconium. And it's going to look, I actually could have shown you pictures, but I decided to spare you. You'll see it enough. But it's sort of a dark, gooey, tarry stuff, sticky. And that'll be there for the first couple of days. That's what was in the baby's intestines in the womb. And it needs to get cleaned out before the partially digested breast milk or poo-poo that comes through. And so that after that 2 to 4 days, then you'll start seeing a newborn stool, which is usually, if it's breastfed, if the baby's getting breast milk, usually a yellow color. And it's often described as soupy and seedy, little curds in it, and then a sort of thin soupy consistency. If it's a formula-fed baby, the color tends to be more green or brown. But whatever color it is, it's all normal. It really, any color is fine, as long as the baby's getting it out. And they will start getting it out quite often once they're born. But it can vary. Some babies are gonna have a bowel movement every time they eat. So you could have eight or more poopy diapers every day. Some store it up and it's every other day, and they'll have a big one. But either of those is fine. And if you're ever worried that the baby hasn't pooped in a while, if they pooped in the first 24 hours and they're still passing gas, they're still farting, that's a sign that eventually they're going to poop in the future, and just be patient and keep feeding them. Something else in the diaper that I wanted to address is something called uric acid crystals. This happens especially in babies of breastfed mothers and is a sign of slight dehydration, but not of any health problem. And what it is these little spots that sometimes parents think is blood, but usually it has more of an orange color, orangey red color. Sometimes though it is red, and it can be spots or it can be like dusted all over the diaper. And that's just something that's in the urine, the first several urines of some babies. It's nothing to worry about. And of course, if you're unsure, you can always take a picture, send us the picture. But you can also look on the internet at this. Plenty of people have posted pictures. If you just put brick dust or uric acid crystals and diaper, you'll see what this is. Another thing is rashes. Newborn skin's very sensitive. I'll talk about that in a future slide as well. But so they'll get diaper rashes sometimes. You're going to want to make sure you change them regularly, get the poo-poo off the skin, try to get it to dry out a little, because being wet all the time and exposed to fecal matter will cause irritation of the skin. But in addition, you can put a lotion on there. The classic ones that pediatricians have told people to use forever is A&D ointment and Desitin, one of those. But really other diaper creams are fine as well. I like the ones that have zinc in it, that are kind of white and thick. I find that they work the best for soothing the skin. If you ever have a rash though, you've done that and it's not going away, it's spreading. Sometimes babies can get fungal rashes or yeast rashes in the diaper, and you're going to want to talk to your pediatrician about that at that point. Let us know, and we know how to handle that. I think that's mercifully all there is about diapers, so I'll move on.
We'll continue talking about cleaning your baby though. So the first bath can be delayed. Here at Mission Hospital, we do delay the first bath. We usually recommend it within the first 6 to 24 hours. The reason for delaying it is that this is good time for mommy and baby to bond. And it also, it's when babies are first born, they do have some problems sometimes with temperature regulation. So we don't want to just blast them with a bath and then cooling off and everything right away. So we do recommend delaying the bath till 6 to 24 hours. Also, in the beginning when the baby is born, if you recall that first picture that Dr. Maynard had, the baby had this white waxy stuff on their face and all over their body, and that's the vernix. There we go. And so that's thought to be protective for the baby as well. So that's why we do recommend delaying the first bath. Babies actually don't need to be bathed that much. They're not super dirty. They're not sweating a ton. And so they don't actually need a bath every day. In fact, after that first bath, you can bathe the baby every 2 to 3 days. Of course, if there's a big blowout or something, you can clean the bottom, wash the bottom, but they don't need a full-on bath every day. Okay. In fact, if you bathe the baby too much, it can dry the skin out a little bit. As Dr. Maynard mentioned, baby skin is very sensitive. It does have a lot of natural oils. So if we strip the baby, bathe the baby too much, over dry the skin, that can cause some irritation to the skin. What else? Sponge baths first. So initially, the baby is going to have an umbilical stump. So the umbilical cord right over the belly button, when you cut it, it's going to dry off, and then it's going to be left. We're going to be left with a stump. So that first few weeks, usually first 1 or 2 weeks, you want to just do sponge baths because you want to try to let that stump stay dry so that it can completely heal. Usually that stump will come off at about 2 weeks or so. Some babies a little sooner, some babies a little later, and that's okay. But you want to try to not mess with that, not get it all dirty with baths. So try to do sponge baths until that stump falls off. When you do bathe your baby, you want to use some gentle soaps. Usually baby soaps are okay. Most baby soaps are made with no dyes or perfumes, so baby soaps are fine. Some quick tips about safety and bathing. Get all your supplies ready. Get your towel ready, get your sponge ready, get your soap ready, get everything that you need for bathing your baby ready, so that you don't have to like run around and try to grab a towel while the baby's still naked. And most importantly, never ever leave the baby alone in the water, even for a moment. Babies can drown really easily, so you want to make sure that you always have a hand on the baby. Don't put the baby there and go answer the phone or get a towel or anything like that. And so make sure you are always supervising the baby. Okay, next slide, please. A little bit about sleep. So we do recommend babies sleep on their back. We recommend a clean, plain sleeping surface that's flat. They don't need very many blankets. They don't need pillows. They don't need a lot of bumpers or anything like that. Just go simple. And a lot of parents would ask me, well, what if they're cold? I do recommend having one more layer than what you are wearing if you're afraid that the baby might be cold. So for example, if you're wearing 2 layers, just your pajamas and maybe your cardigan or something like that, then you could put baby in a onesie like this and swaddle. That's just one more layer. And you can also get long sleeve onesies as well. So that'll keep the baby warm. You don't need a ton of blankets in there to cover the baby. Swaddling is okay. We don't recommend bed sharing. We do recommend that you have your baby in your room. That way you can kind of keep an eye on the baby, and also it's easier for you when you're breastfeeding the baby, but not in your bed. The bed that most of us sleep in are usually, there's too many blankets and pillows and things like that. And also there's always risk that you might roll over on the baby. And I know that a lot of us are very, very careful, very, very light sleepers, but with a newborn, you've never been so tired in your life. So just make it easy on yourself and have the baby in a separate bassinet or crib. We already talked about keeping the crib clear of toys and loose bedding. There's a lot of things that are marketed to new parents, nursing pillows, dockatots, all of these things that are supposed to help your baby sleep. They're not recommended. There's no evidence that they are helpful, and a lot of it can be harmful. So we don't want, even things like, I get the question about dockatots a lot, even things like dockatot, even on their label, it says not recommended for sleeping. So you can watch the baby while the baby's in there and you guys are all playing or watching the baby, but if y'all are going to go to sleep, that's not a recommended safe sleeping surface. We talked a little about swaddling. So you can swaddle your baby, that's okay. If your baby loves swaddling, that's one more extra tool for you to have to comfort them and soothe them and have them sleep a little bit. You can swaddle the baby's arms, that's okay. Once the baby gets a little older and he starts rolling, then you want to make sure that you release those arms, and you could still swaddle on the chest, but you want to make sure that the arms are out once they start to roll, so around 4 months or so. Babies do sleep a lot. Newborns can sleep 14 to 17 hours a day in a 24-hour period, sometimes even more. So they do sleep a lot. However, therefore, usually for short periods of time, 2-hour chunks or 3-hour chunks, you will not get a full night's sleep. And I'm talking about like 5 or 6 hours till they're closer to 3 months or so. So if you haven't had your baby, get used to sleeping a little bit longer, because once you have your baby, you might have shorter sleep periods. I saw a question come up. What's not recommended sleeping surface when parents are going to bed? What's not a recommended sleeping surface? So the recommended sleeping surface is something that's flat and firm. So something like what this baby is sleeping on. We don't recommend baby sleeping on your bed. We don't recommend baby sleeping on anything where there's a lot of pillows. And then there's a lot of merchandise that's marketed to new parents for sleeping that is not recommended. So things like nursing pillows or dakatats, those things are not recommended, because a lot of it does bring the baby's head forward. A lot of it can be choking materials as they are moving their head. And so those are not recommended, and not recommended are bumpers, toys, pillows in the crib or bassinet. So something firm and flat, like what you see here. Okay, next slide.
All right, and so this picture didn't come out quite how I wanted to, but I'm just, and we're getting a little short on time, so I'm just going to quickly go through some common behaviors that you may notice in your newborn baby. All of these behaviors that I'm going to be talking about are normal. So one is newborns sneeze a lot. This newborn here, if you look closely, is getting a good sneeze out. That's entirely normal. This all has to do with the central nervous system, the brain and spinal cord developing control of the body and adjusting different things to the stimulus, to the environment. And it's all a new environment. So sneezing, there's things in the air that are just going to cause a lot of sneezing for babies, but it's fine and normal. Hiccups as well. You'll hear your baby hiccup a lot, more than you ever thought someone could hiccup, but that's completely fine. Although in rare instances, if they're also having trouble with spitting up a lot or with eating, it can be a sign of reflux. However, I'd say 99% of babies, it's not, it's just normal. There's something called periodic breathing that babies do that a lot of parents notice. At first, the baby has changed from being in the womb and having a certain level of oxygen in their blood, and then they're out in the world and it changes, and the body kind of has trouble adjusting to that. So they'll have these episodes where they breathe kind of fast, they'll stop for 3 to 5 seconds, and then breathe again. And parents, they don't truly stop breathing, they just kind of take a pause. And you'll hear that, especially at night, you'll notice when they're asleep. That is totally normal, and it's not harmful. Crossing the eyes, you'll see your baby cross their eyes most likely. That's because their vision really isn't very good when they're born. And so they can't really focus on things yet, and the eyes will cross independently. Usually around the time they're 2 months old, that changes because they can see better and they can coordinate the eyes. And then jitteriness is another thing you'll notice when they're a little scared or upset. You'll see the little chin go, I don't know if you can see that, but bounce up and down, and their arms go. A little bit of jitteriness is normal. And then the last thing, benign, this is something parents also notice when babies are asleep. It's called benign neonatal sleep myoclonus. Let's see, I may have had, yeah, it only occurs while they're asleep. It's not a seizure, although some people see it and are worried. But the baby will be lying there and like their arm will jerk and their leg will jerk, and they can move quite a lot. It's during REM sleep. It's a normal thing. They're just not suppressing their movement enough, as much as we do. but it goes away as they get older. And the way you know it's not a seizure is once they wake up, they're not doing it anymore. It only happens during sleep. So those are some things, if you notice them, granted, you're gonna see them and maybe forget everything I just said. It's okay to talk to us about it, but if you do remember, yeah, these are pretty normal things that most parents will see with their child. And there was a question that came up, so I don't want to jump past it. Oh, did you already answer it, Lisa or Dr. Hoang?
I was just replying. I was just commenting on the Bobby pillow in the picture.
Oh, okay. All right. So, so then I'm going to also talk about some other newborn, normal newborn things. The newborn head. So this picture is of a baby that was pretty recently born, and I'll try to get my cursor over here. So the fontanelle is right near the front, just above the forehead. That's the anterior fontanelle. It's a diamond-shaped soft spot on the baby's head. What that actually is, well, first I'll explain that the skull is not just one bone. It's multiple bones that come together and combine into the skull, but they haven't done that yet when the baby is born. And at the corner of 4 of those bones, it hasn't grown together, and so you get a little diamond soft shape there. You don't have to worry about that. That will close on its own with time. A lot of it can be anywhere from 6 months to 1.5 years before it closes, but the timing of it closing and the size of it really aren't a big deal. Molding, you'll also notice molding, and that's part of the reason, or what molding is when the baby goes through the birth canal, the head gets compressed to help it fit through, and you'll see right when the baby is born, the head looks like an alien head. It's pointed in the back, but that actually corrects very quickly. Within 24 hours, usually most of the molding is gone. And then you can see along this baby's head, if you look closely, there's these little lines. So that's one of the spaces between the skull plates, those bones that I mentioned. And those are called sutures. You notice them more after they're born because the plates have moved, once again, during the molding to accommodate birth, and they will slide back, and those suture lines usually decrease and disappear over time. Other things that you may notice that are a little more of a concern is something called caput succedaneum. I can never say that word, and cephalohematoma, which can also happen during the delivery, which is collections of either just fluids under the skin of the scalp, or sometimes blood, like a bruise, but under a part of the covering of the bone. And that's something we're going to be looking for as a pediatrician. Most of the time, it's something that we don't have to do anything about, but it's good to know that it's there. And then the one other thing I'm going to mention very briefly is dacryocinosis, or clogged tear ducts. Babies have tear ducts. We all have tear ducts between our eye and our nose. But in babies, those can get clogged. And especially in newborns, I've seen this, where one eye will have a lot more tears than the other. And that's because their tear duct is clogged. And as they sleep, those extra tears dry, and they'll leave a little crust or a little goo around the eye. And if you see that, a lot of parents worry about an infection. But if the eye isn't looking red, there's no swelling, it's almost certainly just a clogged tear duct, and that goes away with time without doing anything. And the last thing, I'm going to go very quickly through this, but just some rashes. So I mentioned that baby skin is very reactive. It's in a new environment. It was floating in this nice warm jacuzzi for months. And then it comes out to the real world where all sorts of things can touch its skin. The skin's drier. And so there's certain things you can see. And I have some pictures. So this is called modeling. This you see right after the baby is born, really. And this is because the blood vessels are both closing in some areas and loosening. And so areas are red and white. This can happen when the baby's cold, but isn't a sign that they're in any distress. It's not harmful to them, and it will go away. You see it more when a baby's more pale skinned. Another thing you might notice after your baby is born, it's called acrocyanosis. That just means the feet and the hands will have a darker purplish blue color. That has to do with the blood flow to those areas, and it's a normal part of newborn physiology, meaning it's just something that happens that doesn't harm them at all. And it will eventually go away. If it's showing up, if there's blue showing up on other parts of their body, we would be worried. But if it's just the hands and feet, that's very normal. And then I'll show you some what are called vascular birthmarks. Babies are born with these. About 40 to 60% are born with this called a stork bite or a nevus simplex. Some people call them angel kisses. These are capillaries that have sort of been dilated in the skin, and it's usually fairly light. It happens usually on the back of the neck, between the eyes, and on the eyelids. And so you'll notice that little red color on, probably on half the people talking to me or listening to this will see it on their baby. That's normal and usually goes away, just fades over time. There's nothing you need to do about it. This is on the right is the strawberry hemangioma or strawberry nevus. And that is a collection of blood vessels in the skin. Those also will usually go away with time. Usually by the time they actually grow at first, happen about 10% of infants. They grow after about a couple of weeks to a month old, they'll start growing. And then around 6 months, they stop growing, but stick around. And then after they're a year old, they slowly regress. They get smaller and start to fade away. But it can take up to, the baby could be up to, or well, child at that point could be 4 years old before involution or the process of it going away is over. And in some cases, especially cosmetically, where it's in a place that you really don't want to have a birthmark, it is possible to treat these with medication. But that's really done, that would be a decision for your pediatrician to discuss with you for an individual child. This is something you might notice that's also normal. It's called, it used to be called Mongolian spots. The real medical term is dermal melanocytosis. And it's kind of faint in this picture, but you can see some blue dots in different parts of this child's back, and especially lower down over the gluteal crease where the buttocks start. That is normal. That's a collection of cells called melanocytes, excuse me, which are the same thing that make the pigment in your skin, but they collect in a different place and concentration and can cause these little blue marks. And they're totally harmless and also usually fade away. They don't stick around the rest of your life. Almost through all the pictures here. So then this is erythema toxicum. Happens usually in the first 1 to 3 days in about 20% of babies. These little bumps will show up all over their skin. It doesn't seem to bother the babies, but parents say, oh, my beautiful baby with their beautiful skin, what happened? This is a normal process. It's not entirely clear why it happens, but it's brief. It usually goes away in about a week. You don't have to do anything for it. You don't have to put any lotions on it. It's best just to leave it alone. And then cradle cap, you may have seen, that's like baby dandruff, but it's temporary. It doesn't mean you're gonna have dandruff your whole life, but babies tend to get it. You don't really have to treat this either. Most people will recommend just using a fine-tooth comb or a soft brush, even a soft toothbrush, to gently brush off the skin flakes from this. My first son had it really bad, and it took a year to go away, but usually for most people, it goes away within the first several months of life. And then the final thing I was gonna mention is baby acne. It's not truly acne, that's why I have it in quotes. It's something called cephalic pustulosis. It can take a little longer to go away. It usually shows up later in infancy, maybe at 2 or 3 weeks, and then sticks around for a few months. But it doesn't cause scarring, it doesn't need treatment, and it's not an infection. It's something that's considered normal, and it'll just go away. But of course, if you see any of these things and you don't feel comfortable with them, it's always okay to talk to your pediatrician. So in our case, it would always be okay to call one of us and ask about it. All right, next slide here.
So we're running a little short on time, so I'm going to keep this really brief. A very important topic, but I'm going to keep it very brief. So just like when you're pregnant, your hormones are all over the place, you're moody, your moods are up and down. When you deliver, that may happen again. So it may be completely normal to have some mood swings and some baby blues. Sometimes it can become more serious, and then that can become depression. It's also called perinatal depression. Perinatal actually encompasses both antenatal and postnatal depression. So even when you're haven't even delivered, as you're getting close to delivery, you may feel some of these really severe mood swings, very severe emotions, lack of joy or pleasure, sleeping issues, concentrating issues. So all of these things, just kind of be aware, make sure you have your support, and make sure that you reach out if you need help. There are a lot of supports out there. There are support groups. We are also a resource for you. So we will screen for, we will ask you questions about it, just to make sure that if you do need help, we're going to try to help you find support. Find support from your family and friends. That'll also be a good way to get support for moods, but also try to find people to help you so that you can get through this period.